Today I'm going to talk about the surgical perspective about IBD. I think Dr. Lim actually started saying that there's some common misunderstanding between IBD and IBS, which I'll talk a little bit. It's very common. A lot of patients confuse the two terms. And also, what do we do for anal fistulas, right? So I'm a colorectal surgeon by training. I'm practicing currently in Mount E Orchard and Mount E Novena. All right. So what is IBD? Okay. So if you look, this is a colonoscopy picture, right? Looks quite smooth, right? That's supposed to be normal. But IBD, the insides of the intestine looks like this. Very clear difference, right? So if you can see the difference, right, then you understand what Dr. Lim was telling about. There's inflammation. That means there's swelling. There's actually inflammation going on within the inner lining of the intestine. But unfortunately for us, that's not the only place that inflammatory bowel disease affects. It actually affects the rest of the body. Because basically, it is an abnormal immune response. That means antibodies in our body supposed to help us fight infection and abnormal diseases, right? But it can create an inflammation against our own tissue cells. And you can see from head to toe, right? The words are too small to read, but then right, it can cause fever, it can affect your gut in your food gutlet, your stomach, it can affect your lungs, it can affect your liver as well. And it can also affect your skin, and last but not least, your joints. So they have a systemic form of disease because all these antibodies travel everywhere, right? And the swelling you see in your intestine can happen to give you joint pains, can happen to give you skin rashes that doesn't go away, and also can happen, right, to cause inflammation in the liver that gives you yellowing, as well as in the lungs as well that makes you breathless. And it's, to make things more complicated, it itself is not a diagnosis. It's not the same as, asthma, just one type of asthma. It's got a spectrum of disease. On one spectrum, it's called Crohn's disease. On the other spectrum, it's ulcerative colitis. And it's a spectrum meaning that there's in between. There's indeterminate colitis as well. And why the difference? For us, there's a key difference. Actually, this is one of the key points for why is a surgeon here to talk about inflammatory bowel disease. It is because if you're on this side of the spectrum, you can cure it by using surgery. You remove the entire large intestine, and the disease is gone. Whereas if you're on the other side of the spectrum, you're more or less, basically you have to take medications for life. That's why we have to make the discernment between the two types of the spectrum. Okay, before I go further, right, I'm quite sure, how many of you have never heard of this disease before? Never. Just put out hands, show hands. Quite a lot, right? Never, right? You know why? It's fortunate for us. Because it's mainly a non-Asian type of disease. That means it happens mainly in the West. But then why are we talking about it? Actually, just like what we also noticed that young colorectal cancer patients are on the rise, or the detection is going higher. Actually, there's an increasing proportion of patients in Asia that has IBD. There's also a racial predilection. Amongst Asians, Indians tend to get it more. And between male and female, let's just make a guess. Who thinks that male get it more? A lot of the females put out a hand. I think they want to curse the other gender, like, "Wow, 买了啦, 高了, wow, I already suffer enough." So, then the rest must be, who thinks the female get it more? Female get it more? Then you see typical, no? The guys don't dare to put out hands. Otherwise, I'll go up to your neck. Wow. But actually, unfortunately, females get it more. Yeah, because it's an immune response. It's like that. It's just the way that it is. But don't worry. So, since it's not so common, then when should we be worried about it, right? When should we be worried about it? Generally, the younger patients get it. But if you look at this, these are some of the symptoms that you can look out for. Now, the first sentence is very real. Bloody diarrhea versus blood in stools are different. I'm not cursing, not bloody diarrhea, no. I'm talking about bloody diarrhea really is, you get diarrhea sometimes, right? But you have blood. The whole stools is all full of blood, It's different from when you pass motion and you see blood in the stools. Clear, right? So IBD will get bloody diarrhea, but they don't usually get like normal kind of stools and then blood there. Because the latter, the blood in the stools is more like what? Hemorrhoids, 底层, fissures, other causes. Whereas bloody diarrhea is one of the commonest symptoms for IBD. So if you really pass motion and it's diarrhea and it's blood everywhere, you must see a doctor, because you either have a very bad bacterial infection, which you need antibiotic, or you might actually be the first symptom of IBD. The second thing is chronic abdominal pain. Now, IBS is irritable bowel syndrome. It's very common. All ages get it. And generally, they also always like indigestion, tummy pain, and things like that. But this kind of chronic tummy pain in IBD tends to be persistent and gets worse and worse over time. Whereas IBS, the type of pain, come, go, and when you pass motion, you feel better. But IBD, you don't get that. So again, another helpful symptom to help us think about when I should be worried about IBD. Last but not least, we mentioned that IBD affect other organs. If you have chronic joint pain that is not better, don't always homesick, then go and see TCM. Sometimes it can be related to your joint problems, and it can also be a manifestation of a IBD. So simply, then what is the treatment? Okay, for IBD, so you don't need to focus on IBS because it's really a functional problem and it's not a major issue. For IBD, you really need to think about medication first. Surgery is the last. This center part, immunosuppression, is what we call like biologics. In fact, that has changed the paradigm of treatment of IBD for the last 10 years. A lot of advancement has been made. And there's a very key difference. I show you what are the different types of biologics. This slide is meant to make you all fall asleep. Because I'm sure, like you see, tumor necrosis factor, integrin inhibitors, interleukin inhibitors, 这是我人讲自己听的啦. This is why we study like 10 over years. I still don't understand half of them. Actually, Dr. Lim Li Guan, just now the doctor there, if he's here, he will understand a lot more of this. Because medications, these are all the different types of biologics, right? And over the last decade, there's like even more different types. And some of them has been shown to change the course of disease so drastically that they don't need us surgeons anymore. Because we only come in when the medications have failed. To give you an example of how good the medications are, you look at the chart. The pink one is like an example of a newer biologics. And this particular one called Entyvio actually increases the response rate as well as remission rate. That means you keep the patient symptom-free for a way longer period of time. And that's why IBD-wise, a lot of times we send to gastroenterologists, which is like what Dr. Lim is. He will change and optimize your medications before he seeks us surgeons for a problem. So that's why the indications for surgery, number one is if the medical therapy fails. Number two, when there's complications. As you know, inflammation is basically like swelling and redness and all, right? As it continues, if it doesn't get better, it can cause perforation in the intestine. It can cause narrowing, like a scar that forms in the intestine that will cause blockage to the intestine. And of course, it can also form micro abscesses, infection in the intestine. Last but not least is the quality of life considerations, which include prophylactic surgery. I'll touch a bit about that with a video. So what does it mean? It means that, right, they only look for us is shit happens, but it makes really good stories. Well, the stories I can tell you about IBD patients, wow, super 严重 one. A lot of times is that they have failed so many things that I have to tell them, if you don't do surgery, then there's no other option. So that's why, right, we will have to go and literally into the ICU or when they're very ill, right, to take them out into surgery for high-risk surgery, take out the whole intestine, and then after that, right, they suddenly get better because the gut, which is the source of all the inflammation, is gone. Very high-risk surgery. So to give you an example of what life consideration is, I just mentioned, you remember the ulcerative colitis band? So when you have a full of colon with all that swelling and all, right, and because it's higher risk for cancer, what we can do, right, for them is that we can actually take out the entire large intestine. So this is a surgery for entire large intestine. If you are allergic to it, please close your eyes. But you see, these are the instruments we use. Right? This is a keyhole surgery. Can you imagine we take out the entire large intestine plus the rectum? The first common question I get is that, wow, like that can meh? Can survive meh? Actually, your digestion and absorption happens in your small intestine. So by taking out the whole large intestine, it's actually compatible with life. But then what do we have to do? I have to then use the small intestine, recreate a pouch, a rectum, and join it to the anus. So that, right, the person doesn't feel like the small intestine joins straight to the anus, right? Then every time want to pang sai, right, it's like, wow, keep going in and out. Wow, then very xiong. So what you're looking at, right, this video is that basically, right, I'm actually removing the entire large intestine. These are, you may not understand what are the steps that we do, but I just want to show you how I recreate that part, the small intestine part. Okay, I cannot fast roll this one. Otherwise, you'll be very painful. Can I fast forward this one? Cannot. Correct. Embedded cannot. Oh, so sad. Okay, I try again. Maybe what I do is I skip. Then I play it from here. Okay, I play it from here. So it's a bit smaller. But, yes. Yeah, okay, this is the last part. This part, right, the large intestine. I must show, is it? Okay, can I try? Like that cannot? Cannot, same thing. Cannot fast forward, is it? Then I try just now, then you will skip. Can I try? Cannot. Are you able to show the non-displaying part? Okay, never mind. Okay, okay, can we go back to the... You can screen share this one? I can play this one, but you can screen share this part? Can Can I slide it to that side?
Maybe we can...
there? It's a multi-screen. Okay. Okay. So this part, the whole large intestine is gone already. I enlarge it. Okay, this part, right? This is... Okay, can you hear me now? Thank you. What you're looking at is the anus is in the far end of the screen, and I bring in the small intestine to join the anus. This small intestine, you can see there are some stitches there. You turn the small intestine, a pipe, right, around like a U shape. The center part, you join them and you make a common hole. So now the small intestine is double the lumen size. Then since it's a J loop, right, the tip of it, you use it to make one hole and then you go and join to the anus. Then you have a new rectum. So we do all this by a keyhole. So that means it's no longer like last time, like one big cut. So all this is by small keyholes. And you can see these are the instruments. You see, we use it to pull and we direct the small intestine. We land it. I always wanted to be a pilot, but unfortunately, this is the best I can. I land the small intestine nicely onto the anus, and we join it to make sure that it's nice and fit, so that the patient actually has a neo rectum. This patient is a 27-year-old Indian lady. 27-year-old. And because of the fact that she has very bad symptoms, she cannot go on onto the biologics and all. We then take out the entire large intestine. And finally, we gave her this one. Now she passes motion twice a day, only, because of the fact that she actually did well after that. And she doesn't require any more medication for the IBD. Okay, now we go back to the... Okay, I use this to control. Okay, good. Okay, good. Now we skip to the next slide. Next. Okay. So, you understand now that for IBD, surgeons are only coming in when it's complication, when shit happens, all right? So then, why do you want to talk about anal fistulas? Remember the other spectrum, the Crohn's disease that I didn't mention much about? One of the presentations of Crohn's disease is anal fistula. In fact, our MC just now, when he shared that, he doesn't have one time, he has twice. Sometimes that is a presentation for Crohn's disease. And why does it happen in Crohn's disease? It's because we mentioned that the large intestine is affected by inflammation. But for Crohn's, it affects not just the large intestine, but the anus itself. So, if you look at this diagram, right, by right, the feces should come down from here and out through the anus. But in an example where there is a hole or inflammation, like a pimple in the anus, it forms a tract outside towards the skin, then that's what we call an anal fistula. That's why it's extremely painful if you have an infection underneath the skin here, because it cannot come out. It doesn't go back in and doesn't come under the skin until you actually let the pus come out. Now, anal fistula, presentation-wise, is commonly swelling at the anus, discharge or pain. But a lot of people, when they see this, they think about pulse. So if you know, I mean, I'm happy and thankful for Prime Magazine to invite me for this talk. I also written an article for them, and they have decorated nicely. There are some details there to tell you about the differences between the two. Because it's so common, and it's one of the common symptoms that patients come with, pain in the backside. Basically, backside pain. Then they ask me, what is it? And there are some features there, right, that tell you which one is. If you miss a hemorrhoid, that means if you think you're a hemorrhoid or pulse and you didn't go for treatment, it's still okay. But if it's an abscess and you delay your treatment, then it can be really, really bad, right? For the abscess or infection, you need to start antibiotics and you need to get it drained early, okay? So, but the fistula itself, what kind of treatment do you need? Actually, right, first thing to know is that most anal fistulas, the cause is idiopathic. Okay, C means idiopathic. Actually, it means we don't know. Literally, right, it means that the doctor is the idiot and looking pathetic because he don't know. So most of the causes of anal fistula, right, is really we don't know why it caused. But the closest we get is we explain that it's like a pimple that didn't rupture properly and it just went through the other way. Only some are due to Crohn's, something like less than 10%. And others is due to, like, if you have like prostate cancer or cervical cancer, that means cancers around the pelvis, you get radiation, they can get fistulas. Or cancer causing fistula, that means a cancer in the intestine creating a fistula. Iatrogenic is worse. Iatrogenic means the surgeon, like say if I take out a hemorrhoid, I do a surgery in your anus and I make a hole. Actually, it can happen. Sometimes it's for patients who went through vaginal delivery. Then you know the head too big. Then the vagina get a tear through the anus. Then it can form a fistula. Right? Yeah, that can be really tough to treat, really, really. So usually anal fistulas, unlike that of IBD, which the treatment is medical, is usually surgery treatment. This diagram explains the two classical surgical treatment for fistulas. One, on the one side, you see the abscess there. We make a cut on the outside, the skin there. I use my cursor. Does it work this way? Doesn't. So on the where you see the green color abscess, right? What you do is that, this one. There, correct, okay. Wow. You make a cut here, you drain the abscess, and after that, actually, because the hole is here, right, you need to open up this channel so that the feces don't track underneath there. So we do a fistulotomy. We actually cut part of the anus so that then this thing will heal from the inside out. The other part is a seton. You put instead of cutting the muscle, you put like what we call a plastic or little string across. You let the feces drain out along the string. Then over time, you let this string come out by tightening it and cutting it out. That's a cutting seton. These two are the classical ways of treating fistulas. But unfortunately, this one, because if you cut it, you may end up, your sphincter, right, is for what? Continence, is to control your muscle. If you cut it, there's a risk of incontinence. You can't control your muscle. And this one, because you let it slowly cut out, it may be a prolonged process and it's painful. So they're not the best. That's why, is there anything new? See, got picture again, but we censor the sensitive parts. This is the fistula. What I'm showing is that, of course, this is during the surgery that I just done last week. You can see there's a track, right? Can you see that? Yeah, we demonstrate that there is a fistula from outside. Actually, the outside hole is here, all the way near the groin. Come all the way here, and then towards the anus. And you see this connection? So this technique is called lift. 真的是坐电梯, the lift. We ligate the track that we find. So during surgery, what I have to do is I have to cut and dissect precisely without injuring the muscle on the inside, and the muscle on the outside, I tie it off. So you interrupt the feces from the anus to the skin. Then the whole thing will close off. That's called lift. And then something more fun, again, censor already. Please don't anyhow take photos and share also. But this is a laser. So this is an actual video, again, of a surgery that I did. You see this is the laser fiber. We put it through the external opening. That means the hole. And then, right, as we draw the fiber out, we draw the laser fiber out, we make a burn through the entire tract. By creating cautery or burning energy, you let the thing close by itself. So in this case, again, I don't cut any muscle. And I don't need to treat it with a string over time. Immediately I close it off. Sounds good, right? Fistulas can be most complex surgery ever. Although tying, laser, all this sounds good and sexy, but still there's a recurrence rate because ultimately, whatever we do to that fistula tract, you need the body to heal. You need to form the fibrous scar. And sometimes even by doing all this, the scar can open up again. Then it will recur. That's why fistulas, because always every day must pang sai ma, right? The feces will come down. We always manage during that period of time, right? Their bowel movement as well, and we cover them in antibiotics. And we want the body to have enough time to heal, to minimize the risk of recurrence. Okay? So once it's finished, right, you see the whole fiber will come out, then it's done already. So, in summary, don't go to a doctor's office if you have only one problem. Only go, right, when you have a lot of problems. Make the best buck. Right? What it means is that it's not a shitty problem when you have a problem like fistula. No. It's a shitty problem when you have a shitty doctor. No? So must go to the right doctor. In summary, right, the whole idea is that for fistulas, like we talk about the abscess and all, right, don't just assume that it's due to piles, right? Go and see a doctor if you have pain that doesn't go away. Likewise, like for the inflammatory bowel disease, remember I focus on a lot of the symptoms like bloody diarrhea is not simple, right? If you have chronic tummy pain that doesn't go away again, it's not simple. Don't just take some medicine and walk off. Need to see a doctor early. Then usually when we solve the problem, we find the problem early, it's much easier to solve. With that, I end my talk. Thank you so much.
All right. Thank you, Dr. Chong.
How one knows has pulse or not? Wow, what 看就知咯. You let me 看 what 就知咯. But the truth is that the symptoms of pulse are very similar. You know that there's blood in the stools, there's pain, and there's swelling also. And most of the time, you also know the pulse kind of like bleeding comes after constipation, like hard stools, and then sometimes you feel a bit of pain, and it usually goes away after 2 to 3 days. If you had pulse before, you've seen a doctor before, they usually give you some medicine. It's not wrong. In fact, a lot of people use medication when it occurs again. And if it's better, yes, I think it's fine. But not better, just come and see. All right? Is colon cleanse effective? Would you recommend it? Okay, this colon cleanse means, if I'm not wrong, you're talking about like people put something in the large intestine, then flush an animal, and then clean it on a regular basis, right? Don't. Why? Perforation of the intestine has happened. I know it's not common to get a perforation of that. But do you know that it's actually HSA disallowed? That means a health authority in Singapore. And that it has also been shown that it has no effect to the patient's body. Then a lot of things are purported that they say that it can improve your health, you detox, you improve your cholesterol and all. A lot of people who go for such things, for people who have not heard of this bowel cleanse, right, it's because, it's not medically recommended. But for people who chase after healthy remedies, they are already very conscious of how to take care of their health. So already they are motivated to control their cholesterol, improve their health. This is why they will get better. Not because of the bowel cleanse, but because of the other things you do. So really, it has proven to have no effect and it's really not safe. Okay? What can one do in his or her lifestyle to prevent anal fistulas from recurring? This anal fistula, because most of it is, remember, the idiot and pathetic doctor, we don't know what's the cause, right? So we are also not very good at advising how to prevent it. The key thing that we know that it has to do with, basically, one is hygiene. You know, when we pass motion and we clean, okay, one word of advice here, don't need to use soap, don't need to put anything else, just use water. The anal skin is very sensitive. If you put too much soap on it, right, it becomes red and it gets prone to become inflamed. And what comes after inflammation? Infection and abscess. So other than keeping good perineal hygiene is that make sure that you drink enough water, you don't get what we call straining when you pass motion, so that you don't end up injuring. Because when you're constipated, hard stools, when you pass, you get tears, and that can also cause infection. So those are the only 2 advice I can give you. Next one. I have irregular daily bowel action. Action, not habit. Daily bowel action. Sometimes only once in a few days. Is that a concern? Okay, this is a very common question. There is no such thing as a normal must pass motion every 1, 2 days, 3 days kind. Some people can pass motion once every 7 to 10 days. Wow, yeah, right, like that. Then, wow, bowel cleanse, see already. Because everyone's made differently, and the truth is that we are all sensitive to different types of food. Actually, we always say that, oh, some people are sensitive, but it's always a spectrum. All of us here, right, will be sensitive to different types of food. And it affects by also the degree, that means the amount of that type of food you take. So it's a spectrum. So some people will have the runs. Some people do not need to go. The key to what is then a normal bowel habit is defined by your stools when they come out, right? The nature of stools. Is it well formed? And do you need extra effort to pass? If you pass motion every day, but you have to strain every time you pass motion, that's bad. If you pass motion maybe twice a day, but each time the motion comes, it's hard like a rock, that's bad. But if you pass motion once every 7 days, but your stools are soft, well-formed, you don't have to strain, you pay attention to what you eat and drink all the time, and then that's okay. So there's no so-called set norm of number of times you have to go. Does the getting pulse increase one risk of getting anal fistulas? Pulse and anal fistulas, different problem. They don't affect each other. There's no increased risk either way. Do they manifest as different symptoms? I think we covered that. So for anal abscesses and pulse, they can present very similar symptoms. If unsure, see a doctor. My poop is sticky. Sticky. Is this a concern? It is not a cancer symptom. It's not a worrisome symptom. Sticky poop is usually a result of what you eat, right? A lot of times, if you eat something that is, for example, if you eat a lot of meat, and you don't eat enough vegetables, your poop tends to be sticky. Vegetables and fiber make your poop bulky, less sticky. Can? For a 93-year-old, would you recommend surgical removal of a 4 cm tumor, if not sure malignant, embedded in the stomach wall with top slightly exposed? Wow. 这个是 come down for a consultation, please. Because cannot answer this question. The very fact that you can put so many details there, you are aware that individual needs are different. You can have a 93-year-old who is running marathon. 真的有哦 especially 在日本哦，在 Japan. You can have 93 or you can have a 44-year-old looking half dead after talking to you. Wow, already. So everyone's fitness is different. Age is not an absolute factor against surgery. My oldest patient that went for major surgery, 98 years old, Spain lady, walked into clinic, feisty like anything. Muy bien, doctor. Okay, thank you. Operate. No, he's very, very feisty, very Chong. So age is not an issue. Then all the rest of the surgical details, I need to know. How big, where is the location? It's not just the CM, where's the site? Does it affect other organs? Okay. How to cure constipation? 4 question marks. How to cure? Yeah. So there are many causes of constipations, right? Many causes. It really depends on what is your cause. But I can tell you simply, 70% of Singaporeans' constipation is actually due to our lifestyle. The lack of exercise, the lack of water, and inadequate fiber. 70%. And it's the commonest things that I do to my patients who see me in a specialist clinic is I remove all their laxatives and I tell them, just do these 3 things and you'll be better. And they are. The other things to do with constipation has also to do with, for example, as we get older and older, a lot of times, right, our machinery is actually not as good. We have to change our diet over time. Some people use a lot more probiotics. Some people just try to use like kombucha, natural stuff, chia seeds and all. Anything that's natural, I usually tell them it's okay. It's not harmful, right? But don't just rely on that. If you don't act on your other lifestyle, you don't try to adopt a better, more active lifestyle, over time you will just become more and more dependent, right? You all also know. In fact, the patients are very well informed. They are very scared of taking Western medicine because they feel that only Western medicine can become dependent. Actually, Chinese medicine, natural herbal, you can also become dependent.
最担心的是什么 ？The most worried one is 减肥茶 or the tea, herbal tea. A lot of MLMs talk about herbal tea and all. Be careful. A lot of them actually, okay, I shouldn't say a lot because I really don't know, but some of them contain laxatives. If you use laxatives for a long time, your large intestine, which is basically my specialty, becomes lazy. And by the time you hit 70 years old, it doesn't move. Then you have a problem. You keep coming to hospital because the tummy keep getting bloated. That is what we call very bad functional constipation. So be careful of that. How long will you heal after bowel surgery? Depends on the type. Bowel surgery, conventional, laser, stapler, got a lot of different types. Conventional one takes longest to heal, up to maybe even 4 to 6 weeks. Laser one faster, but it's not suitable for all types. Then there's a stapler where we cut the pulse from the inside, faster to heal. Again, it has its downsides. You really need to discuss with your surgeon about what's the optimal type for you. My husband takes bisacordyl, so these are all the laxatives. Bisacordyl, senna, lactulose, ignite, and he still can't pass motion, but sometimes diarrhea. Wow, some cannot pass motion and then sometimes diarrhea. Make him anxious and depressed. 2 more. So what happens is that, again, it sounds like he has altered bowel habits. He definitely should see a specialist for it, because I'm for one, I can tell you, the 3 main things, the factors I mentioned, I make sure he has it first. I make sure he has a scope that is normal first. Then next, I'll check his hormone, make sure it's not a hormonal problem. Last but not least, I will actually ask him, the constipation that he's facing, is it due to a straining, inadequate muscle relaxation, or is it really he feels that there's something blocking there? So this one tells us the difference between whether it is a functional problem or actually some physical thing that we have to remove. Because if it's a physical problem, then surgery may be the answer for your husband. Colon cleanse, answer already, no need. Kids or elderly pass hard stools once in a week, refuse to drink water, what to do? Please go outside, buy the aerated water. More tasty than normal water. And then after that, they can pass motion. Wow. Hey, I advertise for you. Later I bill you, okay, the invoice. Soda stream. Steady, man. After straining to pass hard stool, then subsequent passing hard stool, feel pain, and didn't even pass, also feel pain. So once you have pain after you pass the bout of hard stools, it's likely you have a tear there. Slight different problem from pulse. It's called anal fissure. Again, can be simply treated with medication. Can see even a GP for it. Very simple. If you pass, I think last question, if you pass motion 5 times every morning, question mark. If you pass motion 5 times every morning, then I must say that you better take MC. No? That's a lot of times. Usually this kind, if I were just to make a guess, is that basically what happens is that in the morning you feel the urge to clear. So you really you have to try to clear them before you go to do your daily work or do your day stuff. There's a component of anxiety there. I'm not saying that you have an anxiety problem, but I'm saying that there's a problem that you feel the need. You need a little bit of what we call bowel retraining. Actually, you need to understand that bowel movements come best when they have the strongest urge and come naturally. Trying to just clear it until you have the song feeling, is not needed for a good life. Okay? Okay, with that, I think we stop. Thank you so much.